Hospice care can be provided anywhere a patient calls home, whether that's in a freestanding home or an apartment, whether that's their own home or a family member's home that they're living with. It can be done in a skilled nursing facility or an assisted living facility, and if need be, it can even be provided in the hospital. It's wherever the patient is when they need hospice care. The difference in the care of where hospice is provided is whether the patient is receiving 24/7 nursing support, in which case they would need to be in a skilled nursing facility. If there's private caregivers available, they could be done at an assisted living facility or in a home or an apartment. And if they're in the hospital, they're already receiving 24/7 care by the nursing staff. So the hospice medical benefit has 4 different levels of care. Starting at the least intense is home or routine hospice, and that's where most of Medicare hospice days are spent, is at home or what the patient calls home. Moving up is the next level of care is called respite stay. And a respite stay is traditionally about 5 days of 24/7 nursing support for the caregiver who may or may not be feeling burnt out or may not have to leave their home where the patient is. The next level of care is called crisis care. Crisis care can be done at home when there's a crisis, a pain crisis, or just an emergency that a nurse needs to respond to at any time of day. And the highest level of care is something called GIP, or general inpatient care. This level of care is reserved for patients that have uncontrolled symptoms that cannot be managed at any of the other levels of care and require 24/7 skilled nursing support to rapidly control their symptoms. GIP, or the highest level of hospice care, is traditionally only provided either in a hospital, a freestanding hospice facility, or in a contracted facility like a skilled nursing home.
There are several levels of hospice care. So typically our patients are at home or they're in skilled nursing facilities, nursing homes. We help families and we help nursing home staff provide hospice care to the nursing home resident or to the patient at home. We provide nurses go into the home to help families understand and patients understand how to use the medications that we provide for the prevention, for example, of pain and shortness of breath. A social worker will go into the house to help with social work issues that come up. We have chaplains that go into the house, volunteers that go into the house. Most of the care, and this comes as a surprise to many people, most of the care is provided by the family or by facility staff. We do provide a limited amount of sort of bedside nursing attendant type care. Many people are surprised when they hear that it's not 24/7. That is not typical of what we provide. So that is referred to as routine level of hospice care. We also provide respite care. Respite is when we will admit a patient from home, typically into our beautiful facility with the beautiful view of the water here in Branford, for 5 days, and that is intended to allow caregivers at home to have some break and relief from caring for their loved ones. You know, sometimes people go on vacation, sometimes people just sleep in a little bit, and that's provided for 5 days. Those patients tend to be relatively stable in terms of their care needs so that that can be transitioned back to the home. We also provide inpatient level of care. In Medicare speak, it's general inpatient or GIP care. And this is sort of very strictly overseen by Medicare. People really have to have care needs, and again, to use Medicare's language, that cannot feasibly be provided in a setting other than in the hospital, which is where we are. So that would be somebody whose, disease may have progressed significantly rapidly over a period of time, and their symptoms have escalated rapidly, and their need for titration of medication dose, supervision of medication administration, provision of injected medications has now sort of made it such that they can no longer be cared for at home. A lot of people are also surprised to understand that the imminence of death is not a criteria for bringing someone into the inpatient setting. They really have to have those needs of having skilled nurses at the bedside available 24/7 to provide care that can't be provided at home. And again, that typically would be rapid titration or escalation of medication doses, frequent dosing of medication, injected medication being needed, delirium, people who are climbing out of bed and delirious, that sort of thing, which really mandates them being in the inpatient setting. And one of the great difficulties that I have, I love my work with our patients and their families, which may come as a surprise because so many of our patients die, but it's a very enriching and gratifying interaction with them. And the hardest part about my job really is having to make an assessment as to whether or not people can come to our inpatient facility or stay in our inpatient facility. And not being able to do that often is a source of disappointment for people. But the regulations are the regulations, and we have to stick by them. Hospice care differs from palliative care in that it is really limited to people who have elected to forego additional disease-directed treatment. So, for example, somebody may have advanced heart failure, advanced lung disease, and advanced malignancy. They've been undergoing, in good faith, treatment with their specialists who've really tried to help them out. The disease has progressed. People are becoming weaker. They're losing weight. They're having pain or nausea or delirium or other symptoms, and they've decided to focus entirely on their comfort. So hospice care is a benefit that is provided by the Medicare hospice benefit. Many also, Medicaid and other insurers also have a hospice benefit. The Medicare hospice benefit requires that a doctor certify that a patient have a prognosis of 6 months or less if their disease progresses as expected. And we're required to provide a number of services. There's medical services, nursing services, social work, durable medical equipment, and so forth. And our focus is on preventing pain, preventing shortness of breath, preventing nausea and vomiting to the extent we're able. We tend to be very good and very successful at that. And that care can be provided in a skilled nursing facility, at home, or in an inpatient facility. Palliative care is probably the most broadly misunderstood medical specialty. First of all, palliative care is, in fact, a medical specialty, and in order to call oneself a palliative care practitioner requires board certification, which requires fellowship training. So people have to graduate from medical school, they have to go through a residency program, and then they have to go through a fellowship program in order to be board certified, and pass exams in order to be board certified in palliative care. Our specialty is known as hospice and palliative medicine. They really are two distinct specialties. Palliative medicine is intended and indicated for people who are diagnosed with serious illness, and is appropriate for people when they are diagnosed with serious illness. It's a broadly misunderstood that palliative care is, quote, what to do when there's nothing left to do, and that in fact is not the truth. Many people, both patients and families as well as medical people, sort of don't think it's appropriate to engage palliative care until treatment options have been exhausted and people are now having progression of disease and are maybe progressing to death. It has been shown that when you engage palliative care earlier in the trajectory of illness, that you get multiple improved outcomes for that population of people. So for example, if somebody has been diagnosed with a malignancy and is undergoing active treatment with an oncologist, it is appropriate for palliative care to be involved. We provide expert-level pain and symptom management. We also are expert in explaining people's conditions to them, helping them understand the trajectory of their illness and their treatment options. And that really helps people understand what's going on and make choices that comport with their beliefs and their wishes. So I tend to think of it as combining pain and symptom management with medical management, and then that all-important counseling part, which helps people decide what they want to do.
Connecticut Hospice is unique in the fact that for our GIP, or highest level of hospice care, we have a freestanding building that's devoted just towards hospice patients. This facility is located right on the water. It has its own pharmacy team, nursing team, social work team. It has an arts department. Everything that's in this facility is devoted just to our hospice patients. We don't take care of any other types of patients when they're here. It's just for hospice, which makes it rather unique because there's only roughly 3 dozen facilities like this in the country.
The single best way to make a determination as to whether or not hospice care would be appropriate for a patient, a family member, a resident of a skilled nursing facility would be for whomever, whether it's a nurse, a family member, a social worker, to ask themselves what we call the surprise question, and that is, would I be surprised if this patient were to die within the next 6 months? And if the answer to that question is, I would not be surprised, that is somebody who is, I think, appropriate for hospice referral.